It's a real pleasure to talk to you this morning about some applications of LITT in the setting of brain metastases. Some of the things I'm showing are Wake Forest material. This is just a Monteris disclaimer. I'm a Monteris consultant. Laser interstitial thermal therapy. Some of you may already be using it and some of you may only be considering it for your practice. But it's an MRI-guided, minimally invasive surgical option for cytoreduction in the brain, and offers an alternative to traditional open surgery. Is very minimally invasive, less than a centimeter incision. I would say most of my incisions are about 1/4 of an inch, and I don't shave patients' hair anymore. It involves stereotactic techniques, but it's able to be used with whatever stereotactic techniques you use. So you don't commit. There isn't a neuroblade specific stereotaxy. Whatever you're using, whether that's CRW, Lexel frames, ROSA robots, Renishaw robots, Globus, Starfix, completely agnostic to the stereotactic technique, but it is a precise, accurate stereotactic type of procedure. It is conducted in an MRI, right? So that's the essential advance, right? So we've made lesions in the brain since the late 1940s, but really the advance here is the bringing together of advanced computing, advanced MR, and advances in MR thermometry. So we can see what we're doing with MR, but we can also measure the temperature. So it's real-time monitoring, which adds a level of precision and safety that I think is a huge game changer and really is what makes LITT so exciting. We can visualize exactly what we're doing and thus ideally preventing any unwanted effects. And there's very short hospital stays. So these patients don't go to the ICU, they go to the floor, and most of my patients are home in less than 24 hours after the procedure. And so it's not magic, it's just like surgery, open surgery, it's just part of our management. So typical concurrent and adjuvant therapies still happen. Brain metastasis patients need radiosurgery, but this is a surgical adjunct. So we'll just take a quick video of what's involved in this procedure. So here's our patient. That's called the robotic probe driver, and they have the guide bolt. The laser is being placed into the lesion in this case. This is an example of the side fire probe, which was a unique feature of the 3.3 millimeter neuroblade probe. And again, the patient obviously would be in the MRI for the actual procedure, and then we can see the neuroblade software. This appears to be an MTLE case here, an epilepsy case, but we're just getting an example of what in cartoon form the laser ablation looks like and ablating a lesion. So this laser is able to heat tissue in a controlled way for duration of time, which allows us to calculate how it's being ablated. And then, like I say, I close with 1 or 2 stitches. Okay, so my journey with LITT began close to 13 years ago. And I personally have a large brain tumor and epilepsy practice, and so we're hoping to have a good question and answer period later. So please ask anything you want about brain tumors or epilepsy if that's of interest to you. Basically, this fits in with an overall practice philosophy that I've been developing to try to optimize patient outcomes through whatever approaches seem best able to do that, with an emphasis on patient satisfaction and safety. And so that philosophy has driven a lot of evolution in my practice over the years, and LITT fits perfectly into that evolution. So just so we briefly touch on it, LITT has many applications in epilepsy, including, of course, mesial temporal lobe epilepsy and other seizure foci, such as cortical dysplasia, hamartomas, cavernous malformations, periventricular heterotopias, tuberous sclerosis, and even corpus callosotomies. For those with interest, I'm happy to talk about those types of applications. But the focus here today is on neuro-oncology, and LITT is an option to consider for primary or secondary tumors, newly diagnosed or recurrent. And really, a lot of its real value is in those difficult to access, or what might have at one point been considered inoperable tumors, so close to eloquent areas. And these can very safely be addressed with LITT, with certain caveats, and that is, for myself, I think of a spherical volume of around 3 centimeters is something I wouldn't necessarily want to go bigger in a single LITT session. But again, you can stage LITT procedures, and that just as we might stage a radiosurgical procedure for a large lesion. And so, when you're talking about things deep to the insula, just near the posterior limb of the internal capsule, in the thalamus, in the region of the basal ganglia, in the brainstem, midbrain, pons. This gives you an option in a way that previously you would have just thought maybe this is only a biopsy patient or it's in an inoperable situation. Also, because of the minimally invasive nature of the procedure, patients who are otherwise frail, perhaps on other systemic therapies, and the smaller you can make that incision, the better. Maybe they've had whole brain radiation before or something, and you're concerned about wound healing and infection, and then having a quarter of an inch incision versus a several centimeter incision may be relevant to that patient. And then of course our patients are on all sorts of different chemotherapies and other types of immunotherapies, and this minimally invasive approach can allow ongoing therapy for that patient, whereas perhaps with a larger craniotomy you might think you'd need a 1 or 2 week window where you stop those therapies. It's an example of that. This past month, I had a patient who, for a lot of sort of logistical reasons, had a biopsy, but we couldn't immediately get her LITT. She started her concurrent Timodar and radiation, and I was able to then do a LITT procedure for her, meaning that she had 1 day where her other therapies were impacted, but otherwise no delay, no change to her adjuvant and concurrent treatment regimens. So LITT has value in all of these domains. This has been recognized by our societies of various kinds. The National Comprehensive Cancer Network, CNS and AANS have all recognized that LITT is a viable and appropriate option in well-selected patients with brain tumors and with epilepsy. And even more recently, just a few weeks ago, the CNS sort of came out again saying that in the context of brain metastases, whether we're talking about recurrence and tumor progression or radiation necrosis, LITT is a viable and advisable option for these patients. So in the context of brain metastases, really our practices have changed, obviously, in the last 10 years. And these patients are living longer, and they're undergoing routine imaging, and so we're identifying many more brain metastases than we did maybe 15 years ago. And so the question is how best to manage these people. And so, of course, there's an incentive for detecting these metastases, because for patients who have symptomatic metastases, they're more likely to die from their brain metastases. So we do want to identify these lesions. And so in identifying them, we're often applying radiosurgery. And so then we're following these patients, right, with serial imaging. And the changes that we see can be challenging for us to know what to make of them, right? So perhaps early edematous change that we're not so concerned about, and that we know is going to resolve in time. But at 6 months, if we start seeing something that had looked like it was getting smaller and now it's rim enhancing and looking larger, is that radiation necrosis? Is that tumor progression? And so this is sort of a clinical situation we find ourselves in more and more frequently. And so in the setting of radiation necrosis, the further out from our radiosurgical treatment, the higher the likelihood that we will be confronting it. And so, sort of plateauing around 30 months or so. So for a good 2 years for these patients, we're sort of looking at, what is the imaging telling us right now? And so those factors that predispose to radiation necrosis, besides time, also are influenced by the dose and the volume of the radiation and whether the patient was receiving immunotherapy, as sort of demonstrated with these slides. And so what are our options for dealing with these situations? So we have post-SRS radiographic progression. The patient's asymptomatic. We may choose just to continue watching it closely, or depending on the size, or depending on, it looks like it's gotten bigger on subsequent scans, we may consider biopsy. Of course, for the symptomatic patients, we're going to be looking at corticosteroids, perhaps Avastin, surgery, LITT becomes an option, and then perhaps some other considerations as well, depending on the patient. And so when we look at the role of LITT in this patient population, those patients who have shown radiographic progression post-SRS and they have biopsy-proven radiation necrosis, we want to look at, well, how does LITT fit into that, and what potential value does LITT have? And so this was a study we conducted and recently published involving 14 centers in the US and 90 patients. And so we see that patients who had LITT were able to discontinue their steroid use within a median of 13 days. And they were able to maintain a good KPS, good functional scores, and they seem to be showing a reduction in likelihood of seizures over time, and again, with little or no disruption in their other systemic therapies. And this LITT for RNN seemed to be a durable effect. If we identified the RN through a biopsy and did LITT, that lesion, for the most part, was dealt with. Of course, we remain vigilant, and ongoing serial imaging is essential, but it seemed in many, many cases to address the issue and do so very safely with a low adverse event rate. So for this patient population, LITT might also be able to support our radiation oncologists and ourselves being able to be, as aggressive as we want to be to treat these patients. We know that the larger volume and the higher dose we treat, the higher risk of either adverse effects or radiation necrosis is. So not to suggest we want to be reckless and still want to be careful, but knowing that we have LITT allows us, an option to deal with this situation if it arises, while still feeling a little more comfortable giving a good strong dose of radiation for these patients. And so in another study looking very specifically at only corticosteroids in the setting of biopsy-proven radiation necrosis versus LITT, we saw that the median time to steroid cessation was around 37 days in that series, where it was 245 days without LITT, which with the side effects of steroids, that may have real clinical relevance to patients. And so what about in the setting of tumor recurrence, progressive disease? Where does LITT fit in? And so we've in this study we looked at LITT plus SRS, LITT alone, and repeat SRS alone. And the findings in this series were pretty striking, that LITT alone or SRS alone certainly had some value, but combined, there really was a suggestion that patients' freedom from local progression and overall survival was definitely increased with that combined modality approach. And so all of these series are influencing how we may want to treat this challenging population. And so it highlights the importance of biopsy, of course, because the symptoms of radiation necrosis and progressive disease overlap. They're not necessarily, it all depends on where this is happening, so as to how the patient's affected by it. And also, very importantly, the appearance on MRI is really no different. You can't, if you see, a lesion on imaging, radiation necrosis and progressive disease essentially look identical. And so misdiagnosing tumor as radiation necrosis could be harmful because it's delaying treatment, right? We don't want to treat radiation necrosis with more radiation, but if it's tumor, then we may be missing the boat. And similarly, if we assume that the radiation necrosis is tumor, we may be applying a therapy that is more radiosurgery in a situation that's actually going to make the problem worse. So I've really, in our group, really feels there's a great value in relatively early biopsy in these patients. And so when we have the tissue diagnosis, we're able to offer more tumor-directed and appropriate care, and that can be valuable also to both our radiation and medical oncologists with some options for treatment, whether with radiosurgery or CNS penetrant drugs. And it just helps us to effectively treat the tumor, the radiation necrosis, or mixed pathology. So it has application and value in all of those situations. And that may allow us to avoid long-term steroids, decrease seizures, and stabilize their function. And so we have a lot of options now. We have, in the setting of radiographic progression in patients, and particularly those for whom have progressive disease, we still have resection, we have repeat SRS, we have LITT alone, and we have LITT plus SRS, and then depending on the pathology, various systemic therapy options. And so as this area has evolved, we're now trying to understand, well, what is the best approach given all these options? And so we're currently at 9 centers conducting the remaster trial, which is the recurrent brain metastases after SRS trial. And this is looking at the role of LITT and biopsy as first-line therapy in instances of radiographic progression in patients who've had SRS-treated brain metastases. And so it's a randomized control trial where the patient comes to the operating room, they have a biopsy, and then they have their frozen, right? They have their initial pathology report, and if they are, if we're found to have cancer cells, then they get randomized. They're in the progressive disease group, and they are then randomized to either only receiving LITT. All of those patients will get LITT. Versus LITT plus SRS. So that's the randomization for recurrent disease patients. And for radiation necrosis patients, the randomization is actually intraoperative, where those patients are randomized to either follow the biopsy up with LITT up front versus no LITT and just ongoing medical management with steroids. And so we're actively engaged in that study at this time, and with 9 sites altogether. And so with the recurrent tumor group, we're interested in looking at time to local progression or neurological death. In the radiation necrosis cohort, our primary objective is time to steroid independence. And of course, we're interested in overall survival and interested in other exploratory outcomes such as quality of life, cognition, exploring the relationships between radiographic changes over time and treatment timelines, and explore a potential role for adjuvant therapies, whatever they may be, including Avastin or other things. And so we'll be excited to see the results there, which will be coming out in the next few years. So the bottom line for LITT here in this part of the talk, it represents an effective cytoreductive technique for brain tumor management. For patients with radiographic progression, LITT provides the same procedure, pathologic confirmation and treatment, right? Biopsy and LITT, and thus allowing for early intervention for recurrent metastases, radiation necrosis, or mixed pathology. And the early suggestion is that SRS after LITT in the setting of recurrent disease or progressive disease may improve local control. And we're studying that in a randomized control way with the remaster study right now. And LITT can decrease time to steroid independence. For those of you who may be considering this and wondering how to get it off the ground, I think the reason that our program has been so successful is that we have real collaboration with our radiation oncologists and medical oncologists. They're very excited about LITT. They're interested in biopsy and LITT for our patients very early. We're in literally daily communication, and I think it's that their interest, their engagement, and communication that makes it really thrive, because everybody needs to be on board for this multimodality approach to their patients' care. And so just very briefly, just to give a little flavor of how some things can be applied. So here's a lung cancer patient. Has some local failure after SRS a couple years down the road. So they had SRS here, and then they're showing some local failure there. So what is that? Radiation necrosis or tumor. And it looks like so we have local failure, right? So we apply LITT in that situation and then follow that up with salvage radiosurgery. So kind of, again, multimodality care there. Here's a patient with very aggressive melanoma showing radiographic progression after a year with increased edema. And so biopsy showed that we had recurrent disease, and we had so we did LITT, and we have really an expansion of the tumor from their original radiosurgical plan. And so because of the size of this lesion, we opted for a hypofractionated radiosurgical approach following the LITT. Here's a patient with lung cancer who looks like they've got progression, and they do, but it's when we look at carefully on gamma plan, we can see that it's really a marginal failure. So this may be a situation where you're just going to need SRS to the region of marginal failure, and maybe that'll be sufficient for their care. Here's a recurrent disease in the brainstem. So again, this is tricky, to say the least, area to do open surgery. With LITT, we have a cytoreductive option that can be applied safely for such a patient. And finally, another tricky recurrence in the brainstem. Given location, this might be one where we want to hold off on LITT, at least at first, and maybe this will be something we treat with repeat radiosurgery. So complex treatment algorithms, complex patient population living much longer than they ever did before. LITT just provides us with a really, really valuable option that can be applied effectively for our patients. Next, we'll have Dr. Leuthardt.
Good morning, and thank you for the opportunity to speak. I really enjoy talking about laser interstitial thermal therapy. I think it's really been a transformative intervention for our patients, and so I'm looking forward to really going through this with you folks. So again, as always, we start with our disclosures, and the most relevant one here is I'm a consultant for Monteris. And so, again, as Dr. Laxton really eloquently put, is that we're fundamentally, we're always balancing this trade-off of the desire to enhance cytoreduction while also preserving function. And so I think that laser in many ways really allows us to strike a new balance that we didn't have before. And so, what I want to talk about initially some of my experience at Washington University and some of the early learnings when we think about this. And so again, this is what we published back in 2017. And again, you can see the distribution of tumors that we treated. Obviously, a large cohort of that is brain tumors, glioblastomas, and various grades of gliomas. Now, the one thing that I think I would emphasize as you are considering laser is that there really is, the more you do it, the better you get at it. That certainly, as we increased our number of cases, that we really started to become faster and more facile. This is a very technical procedure with a lot of steps to it, but it's something that you really can learn and become really efficient with. Now, I'd say the other things that we learned early on was that patients were doing really well with this. As we looked over time, that the number of patients who would go to the ICU, the duration that they would stay in the ICU became less and less, to the point currently our patients don't go to the ICU, they just go to a step down. I think the other thing, and Dr. Laxton spoke about this, and I think that we looked at tumor volume relative to complications. And so again, as you get to around 10 centimeter cubed, that's when you can see an increased risk for having some type of complication. Again, not prohibitive, but it's something to be aware of. So kind of the rule of thumb is around 3 centimeters in maximum diameter is a good limit for kind of considering cases with laser. You can go bigger, but you just have to be very aware that you could have more issues with swelling, potentially seizures. And so just a consideration. So I want to walk you through kind of the experience that we've had and kind of how we evolved in the utilization of this technology. So we started with what we would consider the inoperable tumors. These tumors that you'd be extremely reticent to address with an open craniotomy. So again, like I'd say the poster child of that is the thalamic glioblastoma. And again, this is just one example. Again, very centrally located tumor, and we laser it, and this is the patient 1 year later. And those, again, they're not that common, but they're extremely satisfying. And we also other inoperable tumors that we started to look at is we'd go after tumors in the corpus callosum. Again, those were tumors typically not thought that to go after. And our early experience was that they do okay, but again, that 3 centimeter, that made a very clear difference in how well they did. And so we partnered with Cleveland Clinic to say, okay, for these inoperable tumors, how do these compare to kind of what you'd usually do, which is a stereotactic biopsy? And it was pretty clear that if you had you sufficiently treated the volume and the tumors weren't too large, that they did demonstrably better than stereotactic biopsy. And so that really kind of got us, further confirmed that for these inoperable tumors, that laser was a really meaningful option. So then I'd say we started to expand our scope for kind of what other tumors can we start to think about addressing here with laser. And I put this into the category of difficult to access tumors, meaning we can do surgery, we can take them out, but they are a little bit more technically challenging. And just to kind of show you an example of this, I think, again, a classic kind of difficult to access tumor is an insular glioblastoma. This example, this patient's a 58-year-old gentleman, very healthy, had a history of tremor, but basically started having problems with some gait issues as well as word-finding difficulties. So he presents with this kind of insular, enhancing mass that looks obviously worrisome for a high-grade glioma. Now, that is something you could go after with open surgery. It's in the temporal stem, you'd be a little bit worried about it, but rather we decided to treat it with laser. And when, again, thinking about this, you can kind of see that it's ovoid, so we want to treat it down the long axis of that tumor. And so, again, we did functional imaging, and this is what we call a hybrid scan, where we combine both our DTI and our resting state functional MRI for both motor and language. And basically, that allows us to craft a trajectory, which, again, for these long insular tumors, often will take a transparietal approach, and I'll show you an example of that. So again, we use, here's a 3D reconstruction of the skull with skull fiducials. We're using the ROSA robotic system here. And the tumor you can see in green, you can see it relative to the middle cerebral artery branch. You can see that, again, with the angle of the insula, it's kind of facing downward. There you see the corticospinal tract and the arcuate fasciculus in blue and red, respectively. And so to handle this volume, we had 2 probes going, from the parietal lobe, going down the barrel of that tumor. And we were able to treat, I'd say, around 95% of that volume. So here's what it looked like the following day. I think we were really happy with the treatment. And also, after you laser tumor, you will very classically see kind of this peritumoral enhancement around the area that previously enhanced. And that's really kind of representative of the kind of breakdown of the blood-brain barrier, and I'll talk more about that later. So here it is 1 year later. Again, and that patient, by the way, went home, I think, in post-op day 2, and again, had a very satisfying course and has done well after that. Now, then again, we've started to expand our scope even more. What about operable but craniotomy less optimal? You can take this out, but should you? Um, and I think what really has become a profound workhorse for laser ablation is recurrent glioblastoma, foconodular recurrent glioblastoma, where I can do a craniotomy and I can take that out. But as we all know, that these patients, especially as they're getting the later stage of their course, after they've had radiation, chemotherapy, etc., they are more frail. And so these are great cases. And this is an example of, again, a patient with a recurrent glioblastoma. And again, we lasered that, and this is a patient 8 months later. Again, very satisfying. Also, and again, I'm not going to belabor this, but metastasis post gamma knife, so that has been beautifully represented by Dr. Laxton. So I think the other thing that starts to emerge is, okay, if you have some equipoise of doing open versus a laser, how do these things stack up? And so we looked at our series where we looked at 24 consecutive patients with gliomas in their insula. Again, difficult to access but not impossible. And so we wanted to kind of generally compare that group of patients at our healthcare system to see how similar or different are they. And so the main difference across this everything with that patient population was pretty much identical. The open cases typically had larger volumes, and that I think is in part is because if we couldn't laser it or the volume was too big, we went after it with open surgery. And so in terms of outcomes, again, if we look across ICU stay, hospital stay, discharge to home, post-operative deaths, estimated blood loss, there's really robust differences. Again, there's statistically significant differences in the length of stay in the ICU, hospital, and whether you went, there was a trend towards improved discharge to home with laser versus craniotomy. And most importantly, the post-operative deficits were much less, and statistically significantly so, for LITT versus open resection. And again, it comes as no surprise that there's a significant difference in estimated blood loss. Now, we also looked at outcomes both in progression-free survival as well as overall survival. And again, these numbers don't allow us to do formal statistical comparisons, but the trends, I think, are meaningful in the sense of when we look at progression-free survival or overall survival of open versus LITT, they look pretty much the same. If you look at that these trends are pretty much very similar across these populations. So kind of putting that all together, if these patients are doing relatively the same in terms of their overall survival or the progression-free survival, but with LITT you have a substantially reduced morbidity, post-operative deficits, length of stay, it's very attractive to treat these patients with laser interstitial thermal therapy. So the other thing is, I'd like to talk about what I would consider emerging applications. Like, what am I excited about going forward for some of the additional ways that we're using this? And one thing that I really am interested in now, and we've now kind of had over maybe 1 to 2 dozen of these patients, are this idea if you've got large, low-grade tumors. This one, historically when this would first come across our desk, we'd say, oh, that's too large for laser. That needs to be done open. But if it's a low-grade appearing tumor, you have you have some time on your hands to utilize laser in what I'd call a staged approach. That, again, if you try to treat that all at once with laser, you'd have some real swelling and mass effect problems. But if you try to take it in parts, you laser a certain amount of that volume up front, again, maybe to the maximum of 3 centimeters in maximum diameter. You wait a few months, it's substantially shrunk down. You laser the remainder of the tumor, and then basically, possibly they require radiation and chemotherapy after that. And then this is what you get 12 months later. So you've turned what is kind of a larger craniotomy that has, some meaningful morbidity into it to 2 low-risk procedures. And I think this is absolutely fantastic. So as far as take-home points here, I would say laser is playing a larger role in the management of tumors. Key diagnoses that I would include would be difficult to access gliomas, recurrent gliomas, Mets post-radiation, and radiation necrosis. extent of ablation is an important factor affecting outcomes. And that as we start to think about these lower grade tumors, stage laser is a really great option for some of these tumors. And then finally, LITT does enable kind of novel clinical trials, and I think this is an exciting frontier. And that ultimately, I think the clinical evidence for LITT is substantial and demonstrates short hospital stays, low infection rates, little to no ICU time, and low readmission rates. So with that, I think that's the end for me, and I thank everybody for being here and be happy to take some questions.
In your indications, you listed post-radiation metastasis. Are you not going after virgin metastasis at all?
You know, I would say typically in our experience, we, at least for us, I'd also defer to Dr. Laxton, but usually if it's a classically treatable tumor with gamma knife radiosurgery, I think that, up front is a very reasonable option. But also, and again, I'm sorry to speak for you, but I think that you have enhanced confidence to treat with a higher dose of radiation, so that if you should get radiation, laser is essentially a kind of a safety net for getting, really effective treatment up front. I don't know, Adrian, what do you think?
I would echo that exactly. So for the most part, many METS patients, when they're identified, are going to be upfront radiosurgery. Perhaps somebody has a very large posterior fossa MET that maybe needs to be resected. The patient's got early hydro or something. You could imagine that a patient has sort of a situation of a lesion, maybe is sort of a little bit larger and in discussion at brain tumor board, but it's difficult to access region, and you might think about LITT in that situation. But I'd say for the most part, the role of LITT, the role of open surgery even is a little different in the setting of METS. But so LITT most commonly applied in the recurrent phase or the setting of radiographic progression after radiosurgery.
Will I go first? Thank you very much for both of you. Great talks. In patients that have had METs that have been treated with radiosurgery, and then you're doing the biopsy and deciding whether to do LITT or not, often we're not dealing with all radionecrosis or all tumor. So what are you using to guide your biopsy? Are you using MR perfusion or something else to guide?
Right, good question, and it's the nature of biopsies versus resection. So we always miss relevant features. So either mixed pathology or the we miss the target, and so certainly if there are adjuncts you use in your practice to optimize your biopsies, then by all means sounds like a great idea. Traditionally trying to get at least some of an enhancing rim in addition to what appears to be a more necrotic core, is probably relevant. Most of us would kind of look for that. And of course, the challenge with LITT is that it has to be in the context of this is the trajectory. You're also trying to optimize in terms of laser trajectory. So, what is the position of the tumor and the shape of the tumor? So all of these things go into the planning. I think one of the great values of LITT, though, in that context, is that we really do feel that LITT is a very useful treatment, whether we're dealing with radiation necrosis or recurrent tumor. So even if we got it wrong, and we assumed we'd been treating radiation necrosis, but in fact we just missed some cancer cells, we're still doing the treatment we would have done with that if that biopsy had told us that we're dealing with recurrent cancer. And in all circumstances, of course, we're following that up with repeat imaging. Yeah.
And I think it's really important to highlight that the biopsy is helping inform what happens after the laser ablation, but you're doing the biopsy, you're doing the ablation, and you're achieving a beneficial effect regardless of what that pathology is.
Yeah.
Good morning. Thank you for the talk. Two questions. The first one is, what are your experiences with the recurrent tumors after LITT therapy, and what's the management? Second question is, how do you decide whether to use radiosurgery versus LITT in tumor?
Are you talking about the metastases or gliomas or both?
All cases.
Yeah.
You want to start? Or
Yeah.
I'll start off.
Yeah.
Yes, glioblastoma is unfortunately a very, very difficult problem, right? So that's neurosurgery. So when we do open surgery or we do LITT or whatever treatments we do, we're always faced with recurrence at some point, typically. And when we're dealing with LITT, the circumstances will dictate what we think is the best. Mass effect, shift, patient condition. But as Dr. Leuthardt really beautifully demonstrated, particularly in the setting of recurrence, whether they had an open resection or LITT in the past, LITT might be a very optimal option. Recurrent craniotomies are fraught. They look easy on imaging. The oncologists are wondering why we're reluctant in brain tumor board, but any of us who operate recurrent tumors, it's awful, right? So obviously we do that, but there may be really good reasons for patient outcome and safety to repeat a LITT in that, or to do LITT in the setting of recurrence. When it comes to metastases, the fundamental treatment for many metastases, if they're appropriately sized, and depending on the underlying pathology and the number of mets, of course, is radiosurgery. And in the setting of recurrence, that's when people start thinking, well, we really like to know pathology here, and we want some type of cytoreductive approach. And so depending on the circumstances, we have open resection and LITT. And I think what we're finding more and more is LITT is a really, really valuable and useful and effective option in that situation.
And maybe one thing I would to complement that is that, so for instance, I've been in situations where you've had a recurrence after maybe initial craniotomy, you laser the recurrence, it recurs again at some later date, you laser again. It's not like radiation where there's some prohibition or radiation dosage limitation. That I think I've had a patient where I've lasered in three separate instances where they've had recurrence and brought them further out because of that. So you can definitely use it again and again.